Good morning, everyone, and welcome back to the COVID-19 Community of Practice. I hope you all had a wonderful March break and got a chance to rest and rejuvenate, and we're happy that you're back here today. My name's Ali Damji, and I'm a family physician and the division head of primary care at Trillium Health Partners in Mississauga, and I'm pleased to be the moderator for today's session. Today's session is a great one that's going to be focused on IPAC, boosters, and digital tools for practice, with a specific focus on reducing your administrative burden. And we have a wonderful set of panelists here today who are going to teach us all about just that. I'm going to turn things over to my colleague, Dr. Mekalai Kumanan, the president of the OCFP, to provide the land acknowledgement and introduce the session.
Thank you, Ali. Good morning, everyone. It's so nice to be here with all of you. I'll just take a quick moment to thank our panelists. We know that we couldn't do these sessions without them. And just a reminder that this is a Main Pro accredited session, and you'll receive more details by email. Okay, just moving on to our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories we are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Next slide, and back to you, Ali.
Thank you so much, Mekalai. So for today's reflection, this article in particular really struck me for a few reasons. The first is that yesterday was World Water Day, which essentially is an opportunity for us to reflect on the importance of water, and also the fact that more than 2 billion people around the world don't have access to a clean source. And that includes many Canadian Indigenous communities as well. And in fact, actually, myself, when I was a resident a few years ago, I actually worked in one of those communities that didn't have access to clean water. And you saw day in and day out the tremendous impact that has on a community's mental health, physical health, and just the frank, systemic racism that occurs, when you have policies and procedures like this. And this article is really impactful, especially when you hear the remarks from Marnie Blunt. And one of the things that I'll leave with you to reflect on is Marnie says in the article that this wouldn't be acceptable if this was a settler community, for a community to be without water for this long. And so I think that when we think about how we support Indigenous communities and how we reflectively use our voices to advocate, I think advocating for fundamental human rights like access to water is extremely important. And so I just wanted to draw that to everyone's attention, because while we may often think that things like access to clean water are things that are really problems for the developing world, it's actually happening right here in Canada as well. And we all have a role to play in ensuring that everyone has access to clean water. Thank you. And we'll move over to the next slide. So as Mekalai mentioned, the Community of Practice sessions are Main Pro accredited, and you will have access to the recordings and the curated Q&A after the session as well. In addition, I also wanted to acknowledge and thank both the DFCM and the OCFP for continuing to provide these sessions. Next slide. So we're looking forward to introducing our panelists shortly, and I'll have them introduce themselves in a moment. Next slide. And we're also pleased to also have our additional co-hosts as well, Dr. Mekalai Kumanan and Dr. Liz Muggah as well. Next slide. So now I'm going to turn things over to our panelists to introduce themselves, starting with Dr. Michelle Science.
Good morning, everyone. So Michelle Science, I'm an infectious disease physician at Sick Kids in Toronto, and I'm also an IPAC physician at Public Health Ontario.
Thanks so much. Next, I'll turn things over to Dr. Chandi, Chandrasena.
Hi, everyone. I'm Dr. Chandi Chandrasena. I'm the Chief Medical Officer at OntarioMD. I don't have a lot of disclosures other than previously working with the Ontario Medical Association. Hello.
For myself, I have no financial sponsors or disclosures. Mekalai?
Hi again, everyone. My name is Mekalai Kumanan. I practice in Cambridge, and I receive a stipend for my role both as the president of the Ontario College of Family Physicians, as well as for my role as the chief of family medicine at the Cambridge Memorial Hospital, neither of which poses a conflict for today.
And next, over to you, Liz.
Good morning, everyone. Liz Muggah. I'm a family doctor in Ottawa with Chandi, and I am the senior clinical advisor for primary care at Ontario Health, and I receive a salary for that role, and I have no conflicts to declare.
Thank you. So in terms of a reminder for everyone on how to best participate in the session today, if you have a question, please use the Q&A function on the bottom of your screen. That will allow other people to see your questions, and also they can upvote your questions. So before you put a question into the Q&A, please scan what's already there. And if the question's similar to what you were thinking of, upvote the one that's there, so that way it gets flagged for my attention. For the chat box, please feel free to use that more so for networking or to share your reactions to things. But if you have a question, please put it into the Q&A so that way I can see it as the moderator. Next slide. All right, so I'm going to turn things over now to our panelists. And again, thank you so much for being here. So first, we're going to start off with Dr. Michelle Science, who's going to give an update on IPAC, as well as on the COVID boosters and the current state of affairs for COVID-19 and other infectious diseases. Thank you, Michelle.
Thank you so much, and good morning again, everyone. I forgot to mention when I introduced myself, I don't have any conflicts to disclose. Next slide, please. So for today, I'm going to review quickly the respiratory virus epidemiology. I'm going to talk about some of the historical trends, what we've been seeing in 2022, this season, 2023 season, give a quick update on COVID-19, and then talk about some of the implications for practice, including adjusting IPAC measures in your practice, as well as COVID-19 booster recommendations. Next slide, please. Okay, so starting with historical respiratory virus trends. So this is data from Public Health Agency of Canada, which is really showing two respiratory seasons. The one on the left is 2016-2017, and then 2018-2019 on the right. And you can see it's the total number of positive tests by respiratory virus type. So week 35 is beginning of September. So you can see at the start of September, we see more enterorhinovirus, and then RSV activity starts to increase around October, November, with a peak sometime late December to mid-February, and then drops off by around April. And you can see there's also the other respiratory viruses that are in there that tend to increase over the winter months as well. Next slide, please. So those slides from Public Health Agency of Canada did not include influenza, which is obviously an important virus to think about during that time. So this is also from Public Health Agency of Canada and shows the usual trends in influenza activity. Again, the 2016-2017 season and 2018-2019. And so the red line there is influenza A and the blue is influenza B. And so you can see how influenza A usually increases in the fall, winter, with a peak sometime in January, February, and then it drops off. And then we have that second wave of influenza B sometimes in the spring. Next slide. So again, the respiratory viruses increase in the fall, winter when people tend to spend more time on indoors, and it's not uncommon to see, or we usually see influenza and RSV circulate concurrently. Next slide, please. So just wanted to give a quick update. There's been a lot of talk about what's been happening this season. Next slide. All right, so this is also data from Public Health Agency of Canada, and this is Canada-wide. And this is showing you the positive RSV tests reported by participating labs in Canada. So these are labs that submit data to Public Health Agency of Canada, and it compares the current season to the average range from 2014-2015 to 2019-2020. So that gray shaded area represents the range in percent positivity, and the small dotted blue line is the test positive over that 6-year average. And then that dark blue line that you can see there is what we've experienced this season. So you can see For RSV specifically, the increase started in mid-September, and we really had, I don't know if you probably can't see my marker, but we had above expected levels until mid-November, and then we had expected levels until February, and now we're at lower than expected levels with RSV. Next slide. I don't have corresponding hospitalization data for Canada, but this is from the CDC, and the US experienced a similar surge in positivity for RSV that was earlier. And you can see here, this is, as I mentioned, from the CDC, and it's showing the hospitalizations related rate per 100,000 from RSV. And so that green, that green line with the dots represents the most recent season 2022 to 2023. So you can see the increase in numbers really corresponded also with increased hospitalizations. Next slide. And these are those same data from Public Health Agency of Canada for influenza A and B. And so for influenza A, you can see that dark blue line is the current season, and we had the increase starting in mid-September, predominantly H3N2, and then it was very much above expected levels until mid-December, and we had that peak at the end of November. And now we're at lower than expected levels for influenza A, and also influenza B. We haven't seen the wave starting yet. Next slide. So for SARS-CoV-2, we have no established seasonal trends yet. The current trends are really largely influenced by public health measures and also the transmission characteristics of circulating variants. But you can see this is the same slide for SARS-CoV-2, and really test positivity in Canada as a whole has remained relatively stable. There's obviously local variation. Next slide. And I'm just going to move on to the next slide so that we can, in the interest of time. Next slide. So this is specifically Ontario data now, so not Canada-wide, and this is from Public Health Ontario. And so it's showing you what's happening with the number of tests completed, as well as the percent positivity by surveillance week. So again, you can see there is a delay in reporting. So the last week that's there is at the beginning of March, where you can see it's just above 10%. Next slide. In these surveillance reports, you can look at some of the indicators, which are good measures to appreciate how significantly COVID is impacting us. So you can see here's a snapshot of table 1, which gives you some of the key indicators that we look at. So lab confirmed cases, which also is impacted by testing eligibility and people going out to get tested. Percent positivity, which the last reporting week there you can see is just above 10%. And then outbreaks in institutions like long-term care, retirement homes, hospitals, important to marker and tends to reflect what's going on in the community. Next slide. And then wastewater, you've all heard probably about wastewater. And so another important metric that you can look at, and as you can see, the signal has been on a decline since the peak in December there. And so the wastewater is really looking at concentrations of SARS-CoV-2 across 103 wastewater treatment plants, pumping stations, and sewer sheds in 34 public health units. So they take it, typically they're taken 3 times a week at each location. And just to note that there is a 5 to 7 day lag between the detection of the gene in wastewater and then the diagnosis of cases in the community. Next slide. All right, I did get a number of pre-questions about Omicron sublineages, so I wanted to go through this really quickly. Next slide. And next slide. So Omicron has really been the prevalent variant since November 2022. Actually, if you go back for a second, sorry. Since November 2021, I just wanted to correct myself there. So it was the designated variant of concern November 2021. And then since then, it's really taken over and been very prevalent with a number of different lineages. Next slide. Sorry, it's taking time for the colors to show up. So that slide shows. Oh, apologies. Yeah. Perfect. So this is showing the different lineages. This is the genomics surveillance. And again, the links are there if you want to look at what's happening. And so you can see on the right there, the most prevalent are really the Omicron XBB 1.5 variant, which is a recombinant of two BA2 sublineages. Next slide. And in this report, you can see what's happening. So the far right is the total, but the week 9 there you can see is the most recently reported week. So XBB 1.5 is the most prevalent at 54.4%, and then BQ 1.1 is following shortly after. Next slide. I won't spend a lot of time, but in those genomic surveillance reports, they also show predictions. And so you can see the XBB 1.5 is predicted to remain the most prevalent lineage. Next slide. And just in terms of the risk assessment that's out there for XBB 1.5, there is good evidence of increased transmission risk as well as moderate for immune escape, but importantly, there are no early signals of changes in increased severity, and it does not contain any known mutations that would be associated with the potential change in severity. Next slide. Next slide. All right, so I just want to end quickly. I know I'm running out of time and I apologize, but talking about adjusting the IPAC measures in your office settings. Next slide. So there were several measures that were implemented to minimize transmission and preserve operations. And now that things are changing, we can look at adjusting those depending on what's happening with the respiratory virus transmission risk. Looking at what the goals of these measures are. So preventing harm to vulnerable patients, reducing transmission risk within your healthcare facility, protecting staff, and preserving operational capacity. So there will be a document from PHO released in April that will provide a transmission risk framework that can be used really as a starting point to inform and develop plans specific to your organization or practice around adjusting these measures. But I'm going to provide a brief overview quickly. Next slide. So two of the measures that were incorporated into existing routine practices during the pandemic were routine masking and routine eye protection. There's really limited evidence to support the use of routine eye protection for asymptomatic patients, and most healthcare settings have returned to using eye protection for clinical encounters where it's recommended as part of additional precautions, or there is a need to protect mucous membranes based on the point of care risk assessment. But there is evidence around universal masking for source control in healthcare settings may be associated with reduced transmission and probably is effective for other respiratory viruses, especially those with pre-symptomatic spread like influenza. So for this reason, really masking continues to be discussed in detail, and it's a measure that you may include in your practice based on your risk, your transmission risk assessment. Next slide. So looking at that transmission risk framework, there's really the high transmission risk time periods, which are what I mentioned earlier on during respiratory virus season, when that starts until there's a sustained decline in the community. And then as discussed, we don't really know the seasonality with respect to SARS-CoV-2 yet. So we do need to monitor outside of that typical respiratory virus season for changes. And you can look at things like outbreaks in healthcare facilities, hospitalizations and ICU admissions, as well as community positivity rates and wastewater trends. And in the non-high risk periods, that really encompasses all periods that are not high risk, but just acknowledging that there is a spectrum, and during non-high risk periods, you may still want to include some of the measures that are recommended in high risk periods based on your own risk assessment and operational considerations. Next slide. So I'm going to focus on masking as just because there were so many questions around there. So during all periods, of course, masking should be consistent with any ministry guidance that's out there. And if there's no guidance, it should be consistent with what's recommended for indoor spaces. And I'm just going to break it down to look at healthcare provider masking for direct patient care, in the office space, and then looking at patient masking for direct patient care and waiting areas. Next slide. Okay, so with respect to healthcare provider masking for direct patient care, during those high-risk periods, masking is recommended. The European CDC document talks about this as targeted clinical masking, and that's really protecting patients during those high-risk periods for direct patient care. During non-high-risk periods, you can always consider masking, and some of the things you would take into consideration would be if you're providing direct patient care to high-risk patients, very vulnerable patients like immunocompromised, especially when the care is going to be prolonged. So that may or may not be the situation in your office practice. And then in the general office space, during high-risk periods, you're really going to consider based on the space, the potential for exposure to patients and other staff, and then really the risk assessment in the event of a staff exposure. So if a staff is positive, what would that mean in terms of other staff in that area or potential exposure to patients? In non-high-risk period, again, you're going to consider situationally based on your practice risk assessment. Next slide. So what about patient masking in common areas? So just as a flag, we're talking about asymptomatic patients. Any patients with respiratory symptoms should be provided with a mask and placed in a single patient room. But in terms of a general policy for patients in waiting areas during high-risk periods, masking is recommended, and also important to consider consistency with staff. So if you have a waiting area and you're asking patients to mask, if there's staff that are also in that area, just something to consider the importance of consistency. And then in non-high-risk periods, you can consider masking, and some of the things that you would take into consideration would be if there's close prolonged contact to a large number of individuals, if you have really long wait times in your wait room and people are unable to distance. And then patient masking during direct patient care. So this is when you're going in to see the patient, do you need to ask them to wear a mask? And so really during those high-risk periods, you can consider for prolonged interactions where masking is not going to interfere with your clinical assessment. And then during non-high-risk periods, you can consider situationally based on your risk assessment. Next slide. All right, I am well over time. I'm going to move on to very quickly COVID-19 boosters, another very hot topic in an area we get a lot of questions. Next slide. So you're likely aware of the COVID-19, the Ministry of Health guidelines from February 28th. I've included the link there. There will be, next slide, updated guidance, or I understand there's updated guidance coming from the ministry at the beginning of April. I anticipate recommendations for spring doses will include the high-risk groups previously identified by NACI and the Ministry of Health. So I've listed the groups there: individuals 65 and older, adults of long-term care homes, retirement homes, elder care lodges, and congregate living settings for seniors or those with medical or complex medical needs, individuals 18 years or older with moderate to severe immunocompromising conditions, pregnant individuals or individuals age 55 or older who identify as First Nations, Inuit, or Métis, and their non-Indigenous household members age 55 or older. And just to flag again, lots of questions around the recommended interval. It is 6 months since the last either COVID-19 vaccine dose or a confirmed COVID-19 infection is the recommended duration interval. Next slide. We've included some key references, and I will end there.
Thank you so much, Michelle. And don't worry, you were great for time, so nothing to worry about there. And in terms of the Q&A, there's actually quite a lot of questions here, so I'm definitely going to ask some of the most popular ones here. The first thing, though, just to make sure we're all clear, when you were saying high-risk periods, can you just repeat for us exactly like what that would mean, just so that way we're all clear on what you mean by that?
Yeah, that's great. And I'm not sure if we can go back to that slide. It may be a little bit too challenging, but really high risk periods are really high transmission risk periods. So time periods where there's a high likelihood that respiratory viruses are circulating in a high numbers. So that would be really during the respiratory virus season. So when that starts until there's a sustained decline in community incidence, and then outside of those periods, you're really going to be monitoring what's happening with respect to outbreaks in healthcare facilities, hospitalizations, ICU, and then community transmission. So that those factors would help make decisions outside of that typical respiratory high risk time period if there's another high risk time with SARS-CoV-2. A high transmission risk period. And, hospitals are, and I know it's hard to define that high risk and who is going to be defining that high risk period, I'm sure is the question. And, a lot of the acute care hospitals are monitoring this closely as well. And so, you can always look to what's happening in the acute care hospitals for some guidance as to, how people are interpreting the transmission risk.
Great. And I guess on that point, would you say that right now is a high risk period, where we are currently?
Yeah, that's a great question and lots of discussion around there. I think most people still feel that we're in a high transmission risk with respect to SARS-CoV-2. So things may change and adjust over the next few weeks to months. But as of right now, I think most acute care centers are considering us to be in a high risk just because of outbreaks and ongoing positivity.
Thanks so much. Now, another kind of terminology question here as well, just to make sure we're understanding everything. So when you say prolonged period, is there a specific, amount of time that, IPAC would define as a prolonged period with a patient, or is that just kind of based on your impression?
Yeah, it's there's no time frame that we can put on that. It's really a judgment. I mean, if you're going in and you're going to be, you're in a long-term care home and you're providing direct care for an hour to a patient, then you're in very close contact. That would be a higher risk encounter versus if you're going into your office and you're seeing a patient, but you can be distanced, you're not really in that close contact, that would be a lower risk scenario. So it's hard to put an exact time frame on it. Yeah, I think, and it's really that close contact as well that's quite important to consider whether you can have any distancing and sort of all of the layers that can be put in place, whether those are present.
Mm-hmm. And I suspect, does ventilation play a role with that as well? Because one of the things I think about is, in a family doctor's office, some of us, may have, access to, those types of, really advanced ventilation, and other practices may not, right? And I wonder if that also plays a role there. Is that the case?
Yeah, I think you need to consider exactly what, when we talk about all of the different considerations and how there's really office specific considerations, it's all those layers of protection. It's the environment, the ventilation, your ability to distance when you're taking a history, all of those factors would take into consideration, yes.
Thanks so much. I'm going to now look at some of the questions here in the Q&A. So the first one is actually just a question about what you do as your general practice, because it's always helpful to know what the local experts are doing. So when you're at work and seeing your patients, are you wearing a surgical mask or a fit-tested N95 respirator?
Okay, great question. So, I work at Sick Kids, so I'm following the policies and procedures that are outlined here. So if, currently, if we're seeing someone that is a suspect or confirmed patient with SARS-CoV-2, it is an N95 respirator that we're wearing for those patients who have a respiratory illness and there is suspected SARS-CoV-2, and that's consistent with the guidance from Public Health Ontario, the technical brief that talks about personal protective equipment in those encounters where N95 is recommended, but a surgical mask is an alternative. But here at our hospital, they're recommending N95 respirators. And then for other clinical encounters, I am wearing a surgical mask. where it's not otherwise as my routine sort of source control and mask going in to see patients, unless otherwise directed based on additional precautions because of the patient's signs and symptoms.
Thanks so much for sharing that. The next question also pertains to masking, and is specifically if you anticipate, and if you have a sense of a timeline for this, feel free to share, around when mask mandates at hospitals or healthcare settings will end, or if you think that ever will be the case.
So I can't speak to that. Unfortunately, I'm not sure. I know, that the framework that will come out from PHO is a framework that can be used in the event that there aren't specific mandates or requirements to do so. And that's really where this looking at the transmission risk in the community to help guide practices in healthcare settings. That's what we hope this document will be useful for, but I can't speak to what the ministry or others' plans are.
No problem at all. So another question here kind of goes back to our talk about the risk period. So, someone's brought up the point that it seems like COVID doesn't really have seasonality based on what we've seen so far. So does that mean then that no time could be considered low risk and therefore masking should be routine in healthcare settings anyway?
Yeah, that's a great question. So I think, with respect to SARS-CoV-2 and the fact that we haven't had seasonal trends, it's the trends have largely been influenced by the public health measures and some of the circulating variants. So I think it's hard to know what is going to happen in terms of future trends. It's really hard to predict if there will be a seasonality and what that's going to look like with different variants. So yeah, I see the point. I'm not sure what the future holds, that there may be a time where we would consider it a non-high risk setting. But right now, I think, most centers are considering it still high risk because of SARS-CoV-2. And with some people considering us to potentially be moving in the right direction, but not quite yet because of outbreaks and otherwise. So yeah, it's hard to predict.
Thanks so much. So we've had a few questions here actually around masking again, and specifically if you could point to maybe some evidence around like what's supporting the ongoing, masking recommendations, if you could speak to that a little bit.
Sounds good. Yeah, I think maybe I can send or post some of there have been a number of reviews done on masking and masking in healthcare settings, and just showing how it can be effective at reducing reduced transmission of COVID-19 in the healthcare setting. So happy to share some of those documents that really summarize the evidence well around the benefits.
Okay, that would be excellent. And, to flag for everyone attending today, those resources will be posted on the OCFP website. And there's also a follow-up email that we send after the session. So we'll make sure to include those links there. So thank you for that, Michelle. And then the other question, again, related to masking, definitely a theme here, is around, outside of healthcare settings. So, public indoor venues, sports, entertainment, those types of areas. Now, I know, your talk was really focused on IPAC and clinical settings, but I'm wondering if you could comment on that at all, and in terms of, even just, what you would recommend from an ID perspective for safety.
Yeah, I mean, that's a great question. So really, is this more around sort of advice to patients around what to do with? So I guess, the public health guidance in the community is still that masking is recommended, but not required. So I think people, when they're making decisions going into the community about masking, they really just need to be aware of the risks. And I think people should be aware of the higher risk sort of encounters where you may want to definitely mask. So those prolonged close contact, large number of individuals would increase your exposure risk. And so it's really that sort of personal risk assessment that people should make when they're going into the community and deciding about masking.
Mhm. And I think, there was an interesting comment in the chat that I saw from one of the doctors here where, they were talking about it could be an interesting model where, similar to when you go to the beach and there's a flag saying, green flag, yellow flag or red flag. Like, I wonder if, PHO or, our local public health units or someone could almost have some way to convey that both to the public and to the physicians as well and the providers to say like, now is a high risk period, right? And all of a sudden now we understand that things are operating a bit differently. And I see some other people saying it's a brilliant idea. I can't take credit for it. That was one of my colleagues from Trillium, Dr. David Dane, who had just said that. But I think it's a brilliant idea. So anyway, just a little reflection there.
Yeah, that's great.
Okay, now why don't we turn things over a little bit to vaccines? So one person's question here is, what is considered a booster dose now? Like, is it third, fourth, fifth, bivalent vaccine? Because it's a little confusing.
All right, so I know I do have some ministry colleagues on the line, so hopefully they'll correct me. But I think the recommendation for a booster is that so for 5 and older, eligible that are eligible for a booster, that Ontario is recommending that everyone should have at least 1 booster on or after September 1st, 2022. So I don't think there's a specific number of boosters. It's just that having had one on or after September 1st, 2022 is the guidance.
Thanks so much for that. All right, and then another question, I guess, related to boosters here. So okay, so this one actually has a little bit, I guess, of some context to it. So someone's talking about, their family, and they said that, they personally have had 5 shots, and then their other members of the family have had 4. None of them have had COVID. They're all healthy, other than asthma in one individual being obese. And the question, I guess, is I know if and when we get COVID that we likely are going to have mild or moderate illness, but the concern is the risk to the patients because as a family physician, and then the spouse of the family physician is a teacher. So there's high exposure and potentially, risk to the elderly. So, in that type of context, they've had 5, vaccines, 5 immunizations. Do they still need to get ongoing boosters because of the risk of transmission to the public, even though they may themselves not necessarily get very severe illness?
Yeah, so I think that's a good question. And I think, with vaccines, because of immune escape, et cetera, the goal is not necessarily, it's not necessarily going to prevent all symptomatic infections. The goal is really preventing hospitalization, severe disease, and death, as well as some potential reduction in transmission. But I think, and I think Farine is mentioning that as well. To prevent COVID-19. So I think that for that reason, they can follow the current guidance around, having the booster on or after September 1st, 2022, and, following the other measures that will help to prevent transmission to, vaccine is one of the measures that will help prevent transmission, but there are a number of others that can also support and help protect patients and other interactions.
Great. Thank you so much, Michelle. I'm going to turn things over in another direction, then back to some IPAC questions here. So one of the questions actually is one I've wondered myself too, is there any role for gowns? Because that wasn't really mentioned much when you were talking.
Yeah, that's a great question. So gowns, not for all clinical interactions. So there are specific situations where you need to wear a gown, and gloves is the other one that commonly comes up. But there's only certain situations, and that's when it's recommended as part of additional precautions or your point of care risk assessment. But routine masking for sort of interactions with asymptomatic patients is not something that has been specifically recommended over the course of the pandemic. So it's really when you're seeing a sick patient, it's recommended as part of additional precautions. And when you are seeing someone, it is recommended to change your PPE after those encounters.
Thanks so much. Another kind of practical question here. Do we still need to have room cleaning after every patient? Is that still something that's necessary?
Great question. So I will, and again, I think this was one of the references in my slides, but I can also share it. But there is the PIDAC, the Provincial Infectious Disease Advisory Committee, best practices for IPAC for community practices. And in that, it does discuss about, yes, between all patients, the room should be cleaned.
Okay. Perfect. And on a similar vein, many offices are still doing those questionnaires before patients come in to ask about, their symptoms or travel history, close contacts, et cetera. Would you say that is also still necessary to kind of cohort patients, or what are some recommendations around that?
Another great question. So actually screening for potential communicable infectious diseases should be part of routine practices. So with that in mind, it is something that should continue. And it does help not only for SARS-CoV-2, but other potential communicable illnesses to identify those patients before they come into the practice.
Okay. Awesome. Well, thanks so much, Michelle. I know that was a lot of Q&A and a lot of rapid fire, but you did excellent. And thank you so much for that. And of course, you're welcome to continue responding to questions as well, too, in the Q&A through the system here. So I'm going to now get things ready to turn things over to our next speaker. So if we can move over to the next slide. And it's with great pleasure that I get to turn things over to Chandi, who's going to be speaking with us about a topic that's very near and dear to all of our hearts. So specifically, how do we find time in our days and deal with the growing administrative challenges in our practice? So over to you, Chandi.
Wonderful. Hello, everyone. So I'm going to be talking about something very different than COVID vaccine. So we're kind of flipping completely here. So I'm a family doctor. I'm in about 21st year of practice, and I'm part of a FO in Ottawa. So I started as a fee-for-service solo doctor, small clinic, one staff on paper about 10 years ago. And I started the FO with 7 docs, and now we're on EMRs. We don't have supports or access to allied health. And essentially, if anything needs to be done, the responsibility falls on our shoulders. So that's the lens that I'm bringing to this talk. Next slide, please. So many of you may not know who OntarioMD is, so I just want to give you a bit of a brief summary. So OntarioMD, known as OMD, is a subsidiary of the OMA. It was established in 2004, essentially to get EMRs into physician practices on behalf of the ministry. So in 18 years now, we've had really good understanding of clinical practices and your digital health needs. And we offer change management, practice advice, support through our practice advisors and peer leaders, where we'll come into your clinic and help with you with your workflow and the use of your EMR. We offer lunchtime webinars with our OMD Educate series, privacy and security modules, and we have a fairly large digital health conference in the fall. But what you may not know is that we're advocates for digital health tools at the clinic level, at the region level, and also at the provincial level, and more recently at the national level. So we're involved in a number of provincial digital health projects, and we're one of those voices for community medicine. Next slide, please. So just keeping with our COVID-19 theme for the community of practice session, I just want to mention that we're still offering services for your clinic in terms of COVAXON training and workflow for COVID vaccines. And on our webpage, we have a dedicated area for COVID-19 toolkits, EMR searches for vaccines, and for treatments for high-risk patients and other patients. Next slide, please. So I'm going to give a quick bird's eye view of how a visit in my clinic works using digital tools and add-ons. I'm going to touch slightly on advocacy for decreasing the administrative burden, and then what's coming down the pipeline. Next slide, please. Yeah, so this is essentially me. Next slide, please. So I've heard that most docs only use 30% of their EMR capacity. So if we use our EMRs better, we can decrease some of that burden. There's so much room to learn. A lot of the burden we experience is beyond our control in the clinic, as it requires health system changes, and I know that. But I want to focus on what you can do in your clinic to move that needle a little bit. Admittedly, it's going to take some upfront investment of time, but it's really worth it in the long run. And you can always use that initial investment as part of your CPSO QI project. So you can gain tons of CME credits and find time in your life. So first, you need to identify the biggest pain points in your clinic. Then consider if some things can be automated, like documentation or getting help with time-consuming tasks. One area is to customize your EMR to fit your needs. So use your EMR better, templates, stamps, forms, toolbars. Can you leverage an integrated technology or an add-on technology to take something off your plate? Can you outsource administrative tasks? Can you train and delegate your staff? And it really does take regular review of your workflow to keep the benefits going. And that simplifies your day and helps you find a little bit of time. Next slide, please. So these are the tools that I use in my clinic. So I'm going to put my family medicine hat on, my family doc hat on for this portion of the talk. Because I'm not recommending any of these companies. These are just the companies that I use. So in our clinic, we use Wix.com, which is a free website where we give information and add resources and links for patients. And it comes in really handy when you want to give information about, let's say, vaccines or COVID or what's happening in your clinic. We started using the online booking portal pre-COVID. We stopped for COVID, and we're actually considering restarting it again. So at the moment, our patients can only book by phone. We use secure messaging via Pomelo, which is integrated into our EMR, and it allows us to send messages or information to patients, and we can send out information blasts. We can target patients. We can kind of subdivide our population as to which messages they get. We can send them lab recs, but we can also receive information from them. I use Ocean Forms for patients to fill in prior to appointments, and this saves me time and documentation, but you can also use Ocean for secure messaging. Video visit platforms are best when they're integrated with your EMR and they're easy to use. And there's a link here on the slide for the OH verified virtual visit website to see which ones you should use if you actually want to bill. If you don't want to bill, you can use any that you want, but if you want to bill, you have to use one from that website. So recently, we just had a self-check-in kiosk to see if it would free up some of our staff's time at the front. And also, as mentioned before, the biggest tool is my EMR, and this can be improved on to increase my documentation efficiency and use. Next slide, please. So appointments, you can offer different options. Phone works well, but you can offer other options and see if it'll free up your staff. So there's online booking, portals, emails, texts, walk-in. Next slide, please. So pre-visit prep. So this is about delegation and training and using add-on technology. Yes, we have to pay for it, and it really hurts me every time I pay that bill. But some of the technology really is worth it, and it really saves me time. So it's up to you to decide which ones do that for you. So for virtual visits, staff can call and get consent and put it in the chart, or they can obtain consent via secure messaging. So we use Pomelo. They can also explain about private and block numbers, preferred contact number, no-show fees, that forms will be sent and they should look in their junk mail. This could be done verbally, but also when you use a portal, you can just send a handout. Like it's just kind of, they book an appointment and you get all this information. So it's really important to keep those emails up to date. The portal can be also used for photos that come in or forms or anything that you need from the patient before the visit. So in our office, we always ask for a reason for the appointment or the patient doesn't get booked. This allows us to know how much time to book them, what forms I want to send out ahead of time, what prep is needed, and this can be handled by the staff. Next slide, please. So let's go to my example that I have here. So it's an in-person visit. It's a patient who's booking for depression. So your patient wants to be seen for your same-day urgent spot, and they can't wait 2 to 3 weeks for a regular appointment. But the problem is, so does every other patient. So we send out triaging forms via Ocean and prep for the appointment, PHQ-9, GAD-7, suicidal risk, and others, and also send a list of resources and handouts to inform and triage. For a large number of patients, they don't need to see me urgently, but rather they want resources like psychologists or insurance, and we do this also. So this can be done by the staff, and that prevents that same day appointments from popping up. And this works really well for us because we're a FO and we're lucky that we don't have to bring our patients in. Next slide, please. So at this visit, you'll see that the patient's already filled out the forms. It's integrated into my EMR, and I use that as part of my documentation. So I just type explanations and clarifications. And then I have a custom form or template that I use, which kind of aids me. This patient's on ODB meds, and they can't recall the medication. So I can use Digital Health Drug Repository, which is integrated into my EMR, to check any dispensed ODB meds while the patient is there. And I can also use that to look for vaccines that are prescribed by the pharmacist, narcotics, and controlled substances. And then by the end of my visit, my note is complete. Next slide, please. So after the visit, I can send a summary to the patient or the caregiver if needed. I can send a blood work rec. I usually print out a copy, but I also send one so that it avoids that I've lost my rec piece. I fax to the pharmacy. I can send them a prescription for psychotherapy, and then my staff can deal with it if we're charging for that with e-transfer or Square. And we're actually looking at a third-party vendor for this. So it's a super quick view of technology, and I'm sure I'm already over, so I'm going to go through the rest of my slides pretty quickly. Next slide, please. So what's down the horizon? It's AI scribes. So OMD is doing a lot of work on AI solutions, what's available, what works, what can be integrated, and we're partnering with OMA to do a pilot. So stay tuned for that. The next hot topic is data quality, data exchange. You're going to hear about this in your day-to-day pieces. So patient summary is an important thing that you're going to hear about. Then DHDR, I touched on, DHIR, and then work with OHTs. Next slide, please. So I just want to touch quickly on administrative burden. So we're part of the OMA Forms Committee, where we're working on cutting out unnecessary forms, but also saying no to digital forms and portals that aren't integrated with our EMRs. We're also looking at just interoperability and burnout. We've heard clearly about the administrative burden and the issues with HRM. We've heard it and I experience it. So HRM is a great technology, allows for seamless delivery of reports to your EMR, but now it's an enabler of burnout. So the number of reports sent by the hospital are staggering, and it's the largest contributor of angst. Next slide, please. So in terms of HRM reports themselves, we've done a thorough review of the current state, and we've come up with 6 areas of concern. Not a shocker. The volume of reports we've received, duplication of reports, fax reports, and HRM reports, PDF reports, so they're not searchable. Report categories aren't standard or auto-categorized. The length of reports, not being able to send them depending on your location. These have all been identified. Next slide, please. So in response, last year, we headed up the HRM task force to address these issues, and a great deal of work has been done. We thought we could do this in 6 months, but we've extended it to a year. And a number of our amazing physician leaders, many of whom may be listening today, are part of this task force. And we've had valuable engagement with OH, OHA, hospitals, vendors, physicians. And we're going to come out with recommendations and sending facility guidelines soon. So we'll talk about that later another time. But it's really about decreasing that administrative burden at a health systems level. So I'm happy to come back and talk about that once our recommendations are out. Next slide, please. So I know that was like a super quick overview, and I could probably do a talk on every one of my slides individually. So just a quick piece that if you haven't signed up for our digital monthly newsletter, e-tips, the information is there on how to do that. And it's really about finding something small, something easy to change. Because if you look at your entire day in technology, it's just overwhelming. So you kind of break it into little chunks and find a little spot and then see if you can fix that and help that. And share it with your colleagues if you're lucky enough to have other physicians where each one of you looks at a different area. So thank you so much. In the slide deck you're going to get, there's going to be a lot more slides, which will explain other things that are happening. And I'm happy to take questions. And Ali, I'm so sorry I failed. I've gone way over. So I'm going to leave it up to you to manage the rest of it.
No worries at all. Thank you so much for that, Chandi. And definitely there's been a lot of interesting comments in the chat for sure. People, sharing some of the challenges that they're experiencing, and then some specific questions as well. So I'll start with the first one, because you did bring it up around the duplicate reports in HRM and, the work that the task force is doing. To date right now, though, is there any solution to that people can do in order to help reduce those duplicate reports or avoid them?
Yeah, so, I think what we found out when we did the task force, this is like the first time that anyone has delved into this topic in such detail. So we've spoken to many different hospitals, we've looked at many different systems, we've spoken to many, many clinicians, and the duplicate reports have a lot to do with the faxing, because you're faxing a report and then you're doing a duplicate report. And some hospitals have managed to turn off the fax and some haven't. So what we're doing is we're trying to identify which systems allow for that to happen, and then we're able to disseminate that information to other hospitals, and it'll also come as a recommendation. It's tricky. It's not an easy thing. So it's not that the hospitals are doing it to make our life miserable. It's more that there's a pathway that they have to follow, and it's tricky. And sometimes they don't even realize that they can do it. And that's part of what this task force is doing. Some areas will allow you to speak with your hospital personally and shut off that fax for you, but it's really not standard throughout the province. So it's really hard for me to say who can do that and who can't. And then in terms of the duplicate reports, the other parts is when the reports get addended, or if the reports is written by a learner or a resident, and then it gets signed off and then you get copies of it. And that's part of our task force, is to address, okay, how can we limit that? So those recommendations will come out.
Mm-hmm. And I guess, Chandi, like going back to some of your recommendations too, like just thinking about reducing the administrative burden, someone had brought up a point, which I think is fair, around, our administrative staff themselves, like, are also kind of feeling a lot of pressure as well. And I think there's always the fear around losing staff, especially with the HHR challenges that we're seeing right now in healthcare broadly. So I'm curious, like, when you were talking about the different things that you got your, assistant involved in, I guess, how do you balance that with the other tasks that they have to do, right?
And that's so difficult, because the turnover is huge, and I can attest to that. And I think this is where I'm saying, break it into small little chunks, right? And see if you can work it on as a team. So one year, we did a QI project in our clinic, where we had time and we picked the flow of patients. We mapped it completely out. We got our staff involved in it. We kind of said, okay, where are the barriers? What makes your life easier? And I did say you have to do maintenance on it, so I think it's all fallen apart. But at the time, it was actually helpful for staff to get involved and do it. And they actually thought of ideas that we hadn't thought of. So I think it's engaging them in this and just kind of saying, hey, how can we make this better? What I've noticed is we trained our staff really well in the beginning 10 years ago, but with our turnover and other staff coming in, we haven't given them any training. It's just been, what do you learn from other staff? So they actually don't even know how to use the EMR in a quick, basic way. And so it could just be maybe a lunch and learn to say, hey, staff, this is how you can use it. And that's where you can get OMD to come in, right? So we can come in, and if there's one small project that kind of saying, we just want the nurses to know scheduling or to use their EMR, like tips and tricks, we can come in and do that for your clinic. But we can also do that as a webinar, as a lunchtime webinar, where you can get your nurses to watch or do the recordings after. So I think you're right, it's a very fine line. And I think it's kind of finding what their pain points are and then finding the solution for that. And it's the same as us being overwhelmed. Yeah. If you can fix my problem in the office, I'm going to be much happier than if you're giving me something that doesn't really help.
For sure. I did see the little joke there that someone said, what lunchtime? And
oh, I know.
But I know I know the point's very well taken. Yeah. For sure. And now in terms of I guess actually supports from OntarioMD, I think that actually segues to something I wanted for you to highlight as well, which is the Peer Leader Program. I was wondering if you could speak a little bit about that. And I know that your slides have appendices that talk about that in more detail. Yeah. And for everyone's knowledge, there will be more information about that in the slide deck that's circulated. But if you want to just speak to that, Chandi, I'm sure people will appreciate learning a bit more about that.
Absolutely. So we have an advisory practice, and it's combined between practice advisors and peer leaders. So practice advisors are OMD staff, and they live throughout the province and they work where you work. And they can come in to your clinics to help out and help with the flow, help with your staff, exactly what I just said. Now, our peer leaders are very similar. So the peer leader program is, we have 60 plus peer leaders who are a mix of family doctors, specialists in various forms of payment models. We have nurse practitioners, we have clinic staff, we have office managers. What we find is that if you have, like, quite frankly, if you have a doc talking to a doc, so if I come into your office and I'm like, let me look at your flow, I can really help you here, I really understand what you're going through, it's a lot easier for it to come from me. And so what we do is we open that art of the possible. We say, this is the way my flow is, this is what we do in our clinic, this is how you should use your EMR better. And we get it and we understand it, and we can kind of tweak your flow. What the practice advisors do is they come in and they're experts in the EMR, like they really understand it. So I might be able to tell you, here, do this, tweak your flow, but they're actually going to be able to set it out for you. How do you do it? How does your staff do it? So we complement each other. And it is an amazing program in that our peer leaders tend to be also our educators. So our webinars that we offer, they're all listed on our website. they're given by our peer leaders in conjunction with our practice advisors. So you get that two-prong approach.
Awesome, thank you. And then just so we can better understand your context, we were curious which EMR you're currently using.
Yeah, absolutely. So I should have said that in my conflict of interest there. So I use TELUS PSS. So when I said like what was integrated into TELUS, but each EMR has their own integration of portals or secure messaging, and it's just kind of figuring out which one works for you. And sometimes what's integrated is not what the best tool out there is. So it's about kind of mapping it or seeing if it could handle something else.
Great, thank you. And then just going back to the Peer Leader program there, is there any cost associated with the Peer Leader consult?
No, so right now it's covered because you're an OMA member, and it's part of that. So you have to be an OMA member or be part of a clinic that has an OMA member. So that's it. So it does extend to your entire clinic. Yeah, so currently there is no cost for it. But I was kind of hesitating because in the future, we're thinking of expanding the service and seeing if it's something where we can come and do more. And that's something we're talking about in the future, but currently there's no cost involved at all.
Okay, that's wonderful to hear. And everyone, I guess, at least from Ontario here who's attending will be an OMA member just by nature of the way that the agreement is with the province. So for everyone here who's from Ontario, then that means they have access to that, which is wonderful.
Yeah, and I just want to mention that the webinars, we do them at lunchtime, and that does not work for the majority of docs, and we get that, but they're all recorded so that you can actually watch them anytime you want. You can get your staff to watch them, and they're always on our website.
Awesome. Awesome. Thank you for that. This was another kind of, I guess, practical question around your day in the life. So do you ever get concerned with like a patient who's depressed that they may sometimes be too overwhelmed to fill out the form before they come into the visit? And, how do you deal with that?
No, absolutely. And honestly, I just use the depression as the example that I used for today, but that's kind of the same flow that we use with many patients. And you're always going to get patients who just can't use the portal, who just can't do the forms. And that's okay. So if they can't do the forms, they're still going to get an appointment. They'll get into the same day appointment. There's no problem there. But it triages those who don't need to come in and those who can fill out the forms and who are perhaps it's more coping than actual depression. It's just a way to triage out those that you can so that there's room for those who that can't. And not everyone can use this technology. So you have to pick and choose. 100% you have to pick and choose.
Mm-hmm. And another question came up here, and definitely I'm sure it's happened to you, it's happened to me, I'm sure it happens to everyone, is that, if there's no phone or fax for the doctor, and then we end up receiving a report for someone in error that's, not our patient. I know for me, like there's a lot of other Dr. Damges, and I always get, copied on things that are meant for someone else. And, when I get one of these, I have to, get my assistant to, first of all, track down who's the right Dr. Damge for this person, and then also then, get this report to them. And so, we were wondering, is there some technological fix for that that's being worked on in order to kind of send a report back, or is it still this whole manual process that we need to do?
Unfortunately, it's still the manual process, but that did come up when we looked at HRM reports, that when the wrong report comes in, I know with OLIS in my EMR, if the wrong patient comes in, I can actually say it's not my patient and send that message back. But we still print it off and we still kind of follow through on it. And so right now there really isn't a technological solution for that, but it is one of the ones that we flagged.
Awesome. Thank you. And then another question kind of comes up here around, more low resource settings. So, when you have a clinic where a population does not have access to phones or the internet, many of those communities may not have access to those types of services. So how can OntarioMD potentially help clinics that are serving those types of populations, since their patients, may not be able to pay extra for these types of services?
It's a really good question. And I think it's an important discussion to have about equity and how technology is creating issues with equity for that entire reason. And that's also for areas where they don't have internet connection for whatever reason, or in some northern areas don't have good internet either. And so you can't use a lot of these tools. And I think where we come for that is really that advocacy piece. So we can do workarounds. So so let me break this into two pieces. So one, we can help you with your clinic on what to use with your reality. So if this is your reality, we can help you use your technology maybe more internally, not so much patient facing, and we can help you do that. So that's kind of your clinic level. But I think where this really comes in is that advocacy point. So when we sit at these projects and we hear what's coming down the pipeline and we're able to be influencers or give that opinion, that is an opinion that comes out quite a bit saying, hey, this is great, we're going to do this for the province, but you have to understand this is not the same for everyone, and we're going to create that inequity. So I don't have a great answer, Ali, in terms of how can I concretely fix it, but I think that's where we kind of operate in that.
Well, I appreciate that. And I know it's a very, very challenging kind of issue to solve,
Yeah.
especially with that. But certainly I think that we have to be mindful of that sort of digital divide. And we saw that a bit in the pandemic as well.
Yeah.
And just thinking about how this is a COVID community of practice. I know a lot of us struggled with that early on in the pandemic when we were being, a bit discouraged from, seeing patients in person. And then all of a sudden you have virtual care, but then you deal with these challenges around, people not having access, to the telephone or having access to video. And I think even when you think about the billing codes and the fact that video visits pay more than telephone-based visits, that in and of itself also creates an inequity because some patients can only access the phone, they can't access video. And yet, the physicians are potentially getting a 15% cut, from the billings, and that affects all types of things too. So I think this whole aspect of the digital divide, I think, is really, really important. And I'm glad that it's something that's being paid attention to.
Yeah, and we're actually coming into a new negotiation soon, and I think everyone's been getting those emails. And those are the issues from a digital perspective that need to be flagged. So we also work very closely with the OMA, so they hear that. But I think those are exactly what you just said is what needs to be flagged because those negotiations are going to start soon.
Thank you for that. So this next question, I appreciate if you can't answer this, Chandi, but I'm going to ask it anyway because it was upvoted a lot. So it's around TELUS specifically, and that TELUS is not, like, there's rumors that TELUS is not investing in PSS in the future. Is that something you can comment on or confirm? And if you can't, that's okay.
Yeah, so that's a great question, and I guess as my bias is that I'm on TELUS and our entire clinic is on TELUS, so it also hits me if they're not going to invest in the future. So the conversations that I've had, I know it came out originally feeling that that's the way it was maybe a year or so ago, but they've backtracked quite a bit. And the conversations I'm having is that they're going to be investing in TELUS itself, which is the practice solutions, along with their Input Health. So I haven't heard that they're going to stop. So from that point of view, I like that. They have invested in DHDR, which is the latest integrated technology, and they are investing as they're going forward. But at the end of the day, they are an independent business. So you can't hold me to that. But right now, the signal we're getting at OMD is that they are committed to investing in both.
Thanks so much. And on the subject of DHDR, I think you had mentioned that you've been using that already in your clinic. Now, is that actually integrated with your EMR at this point, or is it a separate application that you're using?
It is. So I'm not using it yet in my clinic. So that I guess when I did that kind of vignette, I kind of fudged it a little bit because I'm on TELUS. But right now, all of the certified EMRs have DHDR integrated into their EMR. So some of you might see little icons when you've updated, or you might see it. In order to actually get it, though, you have to contact OMD and we'll get the process going. Because with all technology, there's always privacy and consent and forms that need to be filled out. And then there's a part that OH has to do to activate it. And then once it's activated, then you have access to it. With TELUS, it's a little bit behind. They're just working with OH right now to get that activated. So they're saying that they're hoping to have it by spring, kind of early to late spring. And then everyone that's on TELUS can access it at that point. Right now, you can access it directly. There'll be a little button. It'll actually kind of launch you right into the clinical viewer or DHDR, and it allows you to view. It only allows you to view right now. So you can't download into your chart. You can't upload anything. But I tell people to be patient. Like, this is the first part of that technology, and those improvements will come. And then there's more technology that's going to build on this technology. Because when you just hear, okay, I can view, some of you might be thinking, well, that's not really that useful for me, but it will be. So it's kind of like the first step is viewing, and then it'll be that bidirectional piece where they can build on it. So it is coming, but for TELUS users, a little bit slower, I'm afraid.
Mhm. And I guess I'm curious about that, piece as well, like around, the future of that, because when we think about the administrative burden and, just these tasks that really, for lack of a better word, kind of grind on people is, one of the ones I always think about is when I see a patient and they're started on a medication by, another consultant, I have to go and manually update my EMR to do it. So when I heard about DHDR, one of the things I thought about is, how nice would it be if, just like so many other things in this world, if, I could just click refresh and then it just, automatically pulls from DHDR, like what meds my patient is on, and just updates my chart for me. Now, I don't know if that's just a dream or if that's going to happen, but, from your perspective, is that what the future might potentially hold for like this?
So that's my dream, I can tell you. I'm like, why can't we do this yet? But yes, that's where it's heading, is that bidirectional flow, right? Same for immunizations, right? So if I immunize in my clinic, I can just upload it into the clinical viewer, and I can download what I need from every other immunization. So right now, DHDR is limited. It's just narcotics and controlled substances. It's the vaccines that are given by pharmacists. So that's COVID vaccines if they're given by pharmacists, but also COVID vaccines in general. Flu shots. So that's something people don't realize, is that next year when you have to look at your flu shots, they'll be in DHDR, because those are the ones that are given by pharmacists, and ODB meds. So that's your younger patients and also your elderly and everyone that's on ODB. And then in time, what we're trying to figure out is how do we get all those medications in there? So those conversations are happening, and that is the future state of that.
Wonderful. And then I have one last question on this topic, and then we'll start to move towards closing out the session. And I think this one also hits very close to home around when you have large volumes of reports coming in, you have a more integrated system, which is it is a beneficial thing for sure. Like, we're more connected with our hospitals, but then on the other hand, there's also more risk associated with it. So, there's comments, showing, that I'm copied on all these reports, how much is my responsibility for them versus the person who ordered it? Like, if I happen to be the one who sees it first, like, where are my responsibilities there? And then also, with all of this volume of reports, I'm not going to be able to necessarily get through all of these in a single day. And so, again, like, what are my responsibilities there as well? So I'm curious, like, does OntarioMD kind of work with the CPSO to get them to kind of understand a little bit more around the technological landscape that we work in and the large amount of things that are coming in? Because I know that causes a lot of angst for people. And I even hear it in some of my leadership work around what is it that I'm responsible for now that everything is coming to me thanks to technology.
And that's a great comment, because we have so many regulators and so many rules, and it's very hard. So we don't necessarily advocate with the CPSO in the way you've discussed. If there's something that we want to work with, we do. So we should work with. We do, like DHDR. We've worked with the CPSO because of their opioid guidelines and narcotic guidelines. What you're describing, it's not that we proactively do that, to be honest. It's more that if there's an issue that bubbles to the top in terms of digital health, then we will go and we'll flag it. But I think we're just another voice that's there. I think for the regulators, we have to have a multi-pronged approach. So we have the OMA, we have SGFP, we have all our other primary care groups. And I think it's more like, how do we influence that? When they send out those emails about, commenting on CPSO guidelines, I'm not sure how many of you actually read that and do the comments. Like, I have to say, I probably don't read most of them, but those are really important to give your input into. So it's a very hard question to answer, because I think it has to be approached from very different areas. And that's a real strong advocacy piece. And even though we do digital advocacy, we don't take on all that advocacy piece. I think that's best left to SGFP or OMA to really push that. I'm going to get some
Yeah,
nasty comments now in the chat. So if you think of a way that we can advocate, I'm happy to look at it. But I just want to be honest, it's not something that we take on. Oh, Ali, I can't hear you anymore. Is it just me? Oh, there you go. Okay.
Okay. I don't know, some Zoom glitch there. But I was just saying, yeah, hopefully at least it's planted the seed around that, because I think it's important. Just in that context, I think around regulation, because I think all of it kind of intersects, and that adds to that stress that people feel when you just have so many things coming at you. The technology's been great in terms of bringing it all to me, but now what am I responsible for, and how do I balance all of that? So I think that'll be a really key question moving forward.
Advocacy.
Okay. And I see actually someone from your OntarioMD board, David Dane, also just commented too that we often bring in the Ministry of Health, the IPC, and other system leaders into the EMR lab or doctors' offices to show them how their policies affect us in practice as well.
Yes.
So that's also
absolutely
really,
David,
yeah.
you come to my rescue there. But yeah, absolutely. And we just had a great, and I think it opens people's eyes, right? Like when we have government officials or people that are making these policies, they come into our EMR lab and they see how we actually function. They're actually dumbfounded that it's not more integrated, it's not more seamless. So I think that's a really good education for them. And we also organize for trips into clinics. So we've had we brought a few of them into a functioning clinic to see how the flow works in the office itself and the monitors and everything. And so absolutely right, that those are places that we advocate for sure.
Awesome. I'm just gonna next call back to Michelle, if she can also just come back on screen as well. And Chandi, thanks so much for answering all of those questions. I know we asked you some pretty tough ones there as well. So Michelle, I know you've been hard at work answering a lot of questions in the Q&A, so thank you for that. And I was wondering if you could just comment maybe on like one or two key ones that you answered that you think people should know, just if they can hear that out loud.
Great question. I'm just scrolling through the ones that I answered to. So just a couple questions around monitoring case counts and some of the limitations of that. So I was just acknowledging that, you know, due to testing eligibility, there are some limitations at looking at just case counts and defining the risk, which is where, you know, you can also look at the percent positivity and other things like hospitalizations and institutional outbreaks to understand sort of the current context of COVID-19. And then another question about the use of rapid testing for symptomatic patients before coming into the office. And so I was just mentioning that there are some limitations with the rapid testing, including, you know, sometimes early on in the course of illness, it can be negative. And so really, you know, basing your point of care risk assessment and your personal protective equipment on signs and symptoms rather than on sort of test results when you're going in to see patients.
Great. Thank you so much, Michelle. So next I'm going to bring up our slide deck again, and we'll just give a few closing comments here. So one of the things I wanted to flag here is an ask that comes from the Department of Family and Community Medicine at the University of Toronto, where we're looking for reviewers for our Improving Quality in Primary Care educational series for primary care clinicians. And so this is an opportunity to review the modules that are there, and it will take approximately 30 minutes to do so. And then there is also a main pro review. That's another opportunity as well. That's a much more in-depth review that would take about 5 to 7 hours. However, there is an honorarium of $250 for your time. If either of these opportunities are of interest to you, please contact Erin Plenert, and the information is there and will be circulated. It's a great opportunity to review these modules and give feedback so they can help improve the experience for your colleagues. And it really ties in well with what we talked about today when Chandi was talking about quality improvement and taking a systems level view. That's exactly what these modules are designed for, is how do we, you know, break things down into small parts and components and then be able to address the pain points that people have in a very systematic way. So QI can be a really helpful tool, and this can be a great way to get started in that journey. Next slide. Can I turn things over here to Mekalai just to give some comments here?
Yeah, thanks, Ali. We just wanted to remind everyone that we are, it's an important time to celebrate family doctors, and so our nominations for our awards are now open. The deadline for nominations is March 26th, and you're welcome to nominate a colleague or yourself. We know that there's a lot of good work happening out there, and it's so important to recognize it.
Great, thank you so much. Next slide, please. And so this brings our community of practice to a close today, and we made it right to 9:15 on the nose, so I'm proud about that. Thank you all so much for your engagement today. We had some excellent questions and really, really great conversations in the chat, and certainly, for some of those advocacy points, the respective organizations will take those back. I also want to thank both of our panelists, both Michelle and Chandi, for their excellent presentations today, and for taking all of our questions today and answering them in such a helpful way. I'd also like to thank the entire team from the OCFP and the DFCM for all of the work that goes into putting these sessions together and making sure that we continue to have them. And then I just wanted to touch on the fact that a recording will be circulated following this session, along with the survey. And please do fill out the surveys and give us advice on what you'd like to see for future sessions. In fact, this particular session and bringing in OntarioMD came from some of the suggestions that were offered. So we do listen to those and really encourage you to give us that feedback. Our next community of practice will be on April 14th, 2023. And the resources continue to be posted on our website. So please feel free to check those out. And again, we're always here. So please don't hesitate to reach out to us. And I wish you all a wonderful Friday and a happy weekend. And we'll see you next month. Take care.